So after that adult case, now let's look at another pediatric case. This is a small child, again, similar to the case one. I think this child was just under 15 kilograms, with a defect that was a little bit larger than the first ones and some deficiency of the SVC and posterior area of the septum, as well as stretching forward towards the aortic rim as well. So this patient, 14 kilograms, a little bit too small for a 3D transesophageal probe. So therefore, we did this with 2D. Now, my usual practice is only to avoid balloon sizing if we have 3D transesophageal echo available. In this case, the 2D imaging was so exquisite, and without trying to sound arrogant, because of our experience with this device and with echo interrogation without balloon sizing, again, we didn't place a sizing balloon, but I would again say that I would recommend that with the Gore cardioform ASD device, particularly early in your practice, that you do use balloon interrogation and balloon sizing of the septum and defect. So given the deficiency of the SVC and the aortic side, we wanted just to make sure we were going to have good grip on that rim, and therefore another consideration is whether you would go up or down with device sizing to make sure the device sticks in place. So you can see here in the top left, really quite a deficient 4 to 5 millimeter SVC rim, which I think is a concern. And you can see because of that, as you move towards the pulmonary veins in this little sweep, you can see that as the pulmonary vein comes in, not a huge distance between the start of the defect and the pulmonary vein as well. And posteriorly on the view down here, you can see only a 4 to 5 millimeter rim. So, a challenging case in a small patient. So 16 millimeters would sit in the middle of the 32 millimeter range without balloon sizing. But again, if we had a balloon sized here, I would wager that the device size would have fit with the IFU of a 37 millimeter Gore cardioform ASD occluder, and therefore we elected to move up to a 37 millimeter device. Now, I think these slides are quite important, and this for me shows the importance of first of all locking, but also making sure you've got as good a position as possible. So although these two views don't look very different, the bottom right and the top left here look like quite similar echo views. And the bottom right here, I would wager and suggest to you that this piece of septum here can be seen passing across the disc and into the waist of the device, which is in this plane here. And up here towards the aorta and SVC, you can see this piece of septum comes into the waist here. Now you can see the same case for the aortic area here, but here, I think the septum here doesn't quite make it into the waist. I think the septum underrides this disc. And I think you'll see what I mean in a second. So the other thing is the device looks mobile here. The device is moving up and down. This is before it's locked, but because the point is here, I don't think we've captured that rim with the locked device, and that's very, very subtle and difficult to see unless you note the sort of movement of the device and the fact that there's color flow in that area, which is not really present in the bottom right frame. Now, if I pause that, if you look up here, you can see again what I alluded to, the device really not being caught properly by this area of the septum, which you remember was slightly deficient in the transthoracic. And if we therefore bring this down and just examine it, you can see again in this area, septum and device. So it does not look like the septum goes in between the disc of the device, which I think does look subtly but significantly different here. Again, in this case, the aortic rim is also deficient, and you can see here the device, does it look okay? It's difficult to know. There's color flow sweeping in behind the aorta and through here. And the key thing to note is this device has not been locked, and therefore the reliability of the final result before locking the device here, it's really difficult to be sure. From my point of view, the only thing you can say for sure is that there's left disc on the left side and right disc on the right side. And until you lock the device, it's very difficult to be more firm than that. So after the device has been locked in this case, you can see a much better alignment. You can see again the slight prominence into the SVC down here. Start of this sweep. Play that once more for you. So down here where the SCC starts to come through, you can see the color flow accelerating through the SCC. And likewise with the right pulmonary vein, we knew this was going to be a concern, but the Doppler pattern looked good and looked to improve as we went on. And again, you can see here that aortic portion has tightened up quite nicely, and you can see now there's a much more comfortable, aortic splay and much better looking apposition to the aorta after the device has been locked. So this is important. So the position that the handle is in when you're deploying the device can really help you or hinder you. So in the panel on the left here, this one, the device is being extruded with the handle in a neutral position. So as it lays on the table with the controls of the handle facing up towards the operator. And pay attention to the way these pedals behave. They're not really looking very beautiful. It's difficult to comment objectively and say what's going wrong, but these pedals here don't look as if they're quite in the right place. And it's making the device all just look a little bit strange when it forms up. Now on the other side, you can see several things. The orientation of the delivery catheter is quite different. And hence you end up with the ability to say that you could set a saucer on top of the left atrial disc of the device. And the reason is what I've done here is rotated the device between 90 and 180 degrees clockwise by rotating the entire handle. That has pointed the device posteriorly and allowed the left disc, the left tulip of the device to have a better orientation towards the septum. So when one pulls the device down onto the septum, which you can see is happening here, you get this much more symmetrical saucer-shaped left side. And then as the right disc forms up, you can see splay, and much more likely in this example on the right pane here to have captured the different parts of the atrial septum. That's really important. So in this schematic, you can see as that these petals form up, you can see slightly odd looking bulging of the petals here. Difficult to describe, but it doesn't look right. And in this view, you can see a much more symmetric cup-shaped in 3-dimension, or sorry, saucer-shaped in 3-dimension orientation and shape of that left disc. And really key, again, this is a small child with floppy rims and deficient rims. So we got the device in place, it's got both sides, and with locking, you see this relatively slow but quite substantial 90-degree pivot of the device. So just look at that once more. So the locking loop is in situ here, as we saw in the first case, and now the pigtail of the locking loop has been formed, and the device has rotated a full 90 degrees. And then as we take in this small child, take the suture away, we can see that even the support of the suture and the catheter without being firmly attached will change the orientation of the device somewhat. Not hugely, but will change it. And I think here, just demonstrating the change in the orientation of the device, you can see that the device has moved 90 degrees effectively on locking, and that's really important to take into account in small children. Again, you can see here just after deployment, you can see the slight turbulence of the SVC, but again, in my experience, this just goes away over a short period of time.